Good evening, participants. Thank you for joining Sheel Connect, and thank you for being participating with our today's session. Today we are having a session on pre-eclampsia management, current and future trends in association with the Bhimvaran Society of Obstetric and Gynecology. And the further session will be taken over by Dr. Sujay Shri. So I will hand over the session to ma'am. Ma'am, we are glad to have you on our platform, and I hand over the session to you.
Hello.
Yes, ma'am.
Has taken the opportunity to talk on our forum, and a very special mention that this is one of the first meetings we are having on our platform, Biomarkers Obstetrics and Gynecological Society. It's been exactly 4 months since we have had our installation ceremony, and sir is the first speaker we are having on this platform to address our members. Is pre-eclampsia. I will now request our President, Dr. Lakshmi Madam, to introduce the guest for today's session.
Thank you, Sujashri. Good evening, everyone. I welcome you all to the first scientific meeting of Bhimvaram Obs and Gynec Society. Today's topic, management of pre-eclampsia, current and future trends. We have with us Dr. Sanjay Gupta, sir. It is the honor of BOXY to start its academic journey with such an accomplished speaker. I thank Sheel for arranging this meeting. Sir is the FOXY ambassador to FIGO and also the ethics committee chair for this prestigious international society. He is the Secretary General for World Gestosis Organization. He was conferred FRCOG by the Royal College in the year 2010. He was the president of FOXY in 2010 and president of BIPSI in 2013. He has more than 150 publications to his credit, has authored several books which are useful to the students and practitioners. He is a professor and postgraduate teacher. He is currently the director of Gupta Hospitals and Green Array Genomic Research and Solutions. It is a privilege to have you with us, sir. Welcome.
Thank you so much, Lakshmi ma'am, and my congratulations and compliments to the newly born society, the neonate, and I think it's my really honor and privilege to have the first stay with you. So, and I think this is a topic also that you have chosen very appropriate, and I'm very happy to talk about. I hope you can see the screen and hear me also clearly.
Yes, so you're audible and the screen is visible.
Yeah, thank you so much. So, pre-eclampsia in its management, the current status and the future trends. Right. Hypertensive disorders in pregnancy are a spectrum of disorders ranging from already existing chronic hypertension in pregnancy to complex multisystem disorder like preeclampsia, leading to complications like eclampsia, HELLP syndrome, pulmonary edema, stroke, and left ventricular failure. The National Eclampsia Registry of FOXY ICOG statistics reveals that the incidence of hypertensive diseases during pregnancy to be very high, with a substantial incidence of preeclampsia. The magnitude of problem is really surprising. In our country, incidence of preeclampsia was found to be 10.3% by the National Eclampsia Registry, and the incidence of eclampsia is 1.9% of all the pregnancies. That means in India, we have 26 million deliveries per year, that we are dealing with 26,78,000 cases of preeclampsia and 4,94,000 cases of eclampsia yearly, which I think is astounding, and it's a truly task to deal with such a situation. What we have to now realize is that there is a new definition of preeclampsia, and this was revised in 2014. So what it says now is hypertension developing after 20 weeks of gestation with one or more of the following: either proteinuria, maternal organ dysfunction, including renal, hepatic, hematological, or neurological complications, or fetal growth restriction. So it is important to note here that this definition does not require proteinuria to meet the diagnostic criteria. The inclusion of fetal growth restriction is there in this definition, and it may increase the number of women meeting the diagnostic criteria for preeclampsia, and is therefore a significant change that we have to note. So what is the original classification of the hypertensive diseases? And the World Organization Gestosis in a classification of HDPs is like this: gestational hypertension, blood pressure equal to or more than 140 by 90 millimeters detected beyond 20 weeks of gestation and which returns to normal within 42nd postpartum day and is not associated with any other features of preeclampsia. Chronic hypertension, known case of hypertension or a case of hypertension detected before 20 weeks of gestation in absence of neoplastic, trophoblastic disease and malignancies. Preeclampsia, we have just seen the new definition. Then superimposed preeclampsia is the one where there is occurrence of preeclampsia in women with chronic hypertension. And eclampsia, it is the occurrence of seizures in association with preeclampsia. It can also occur as atypical eclampsia. This is a classical classification, but it's the clinical classification is more important to us in practice. So what are these clinical classifications? There is early onset preeclampsia, onset of proteinuric hypertension before 34 weeks of pregnancy. The maternal complications are here more severe, and low birth weight, fetal growth restriction, iatrogenic prematurity are more common in this situation. Late onset preeclampsia, onset of proteinuric hypertension after 34 weeks of pregnancy. Here the maternal complications are less severe. Low birth weight and fetal growth restriction is less common. Then there is another way we can classify clinically the hypertensive diseases. One can be non-severe preeclampsia. It's not called anymore as mild preeclampsia, mind you, and I'll tell you the reason later. The blood pressure is more than 140/90 and less than 160/110 millimeters. No premonitory symptoms and normal HDP laboratory parameters. While severe preeclampsia, blood pressure is more than 160/110 millimeters with or without premonitory symptoms and with or without abnormal HDP lab parameter, or also if the blood pressure is more than 140/90 but with premonitory symptoms and or abnormal HDP lab parameters. And that's why it's not, initially, as I said, it's not called as, mild and severe, because it is, we have to note that non-severe preeclampsia may get converted into severe preeclampsia in a very short time. And that's why vigilance is very, very important in these cases. So now, considering this magnitude of mortality and morbidity, especially with preeclampsia, there can be no two opinions regarding early and universal screening for these conditions. So, but what is required is the simplification of screening process. As the tests available today for screening are complicated and are costly, there is certainly a need for simplification. We know that there are more than almost 120 different parameters, starting from olden days of rollover test and what you have you to the latest the biomarkers in the field. So that's why we came out and tried to simplify the screening for preeclampsia. And what have we done with through Gestosis organization is we have come out with the Gestosis score. And this Gestosis score is basically based on a very good history taking and the simple measures that you would like MAP that you have to observe during the pregnancy of that particular patient. And I would like to emphasize again that history taking is many times given really a least important, especially in medical colleges where the lowest rung doctors, usually interns or junior doctors, are told to take the history of the patient and not told the importance of their history taking. And that's why many times the clinical history is deficient. And I think this needs to change, and we have to emphasize that clinical history taking is always important in any clinical situation, may it be preeclampsia or any other thing. So how do we score the risk in with Gestosis score? This score involves all the existing and emerging risk factors in the pregnant woman. Score of 1, 2, or 3 is allotted to each clinical risk factor as per its severity in with careful history and assessment of women. Total score is obtained from time to time, and when the score is equal to or more than 3, the pregnant woman should be marked as at risk of preeclampsia. Now, this is the list of the history taking points that we'll consider. Don't worry about copying it right now, because there is a free app available on Google, which is called as a Gestosis score app, and my friend Dr. Mandrupkar has created this, and this is now available freely on the Google. So these are the various points. As you can see, the age, the older and the younger, maternal anemia, obesity, primary gravidity, short duration of paternity, women born as small for gestational age, polycystic ovary syndrome, interpregnancy interval more than 10 years, conceived with assisted reproductive treatment, MAP, then chronic vascular disease, excessive weight gain during pregnancy. All these get 1 point. But there are some more higher risk factors which contain maternal hypothyroidism, family history of preeclampsia, gestational diabetes, obesity, BMI more than 35, multiple pregnancy, HDPs during previous pregnancies, pre-gestational diabetes mellitus, chronic hypertension, mental disorders, especially like schizophrenia, inherited and acquired thrombophilia, maternal chronic kidney disease, autoimmune diseases, and pregnancy with assisted reproductive technique, especially with embryo donation or ovum donation or surrogacy treatment. Now, believe me, we have gone through almost more than 1,000 of various references to come down to this, and for every point that is given, there are multiple references available in literature why these points are given importance and the score as we have mentioned here. What is the significance of this score? Unlike other guidelines which consider each factor as of equal significance, the Gestosis score gives weightage according to the severity and the importance. While completing the score sheet, it allows points to be kept blank. If the patient is unable to give the history, for example, patient may not know whether she herself was born small for this or whether her mother had the preeclampsia in her pregnancy. So it denotes that indication for available prophylaxis, and we the predictability and preventability is important, but what is important is the prophylaxis with aspirin and calcium, and that is what we can once the score is 3, one can safely go for this prophylaxis with low dose aspirin and calcium, and that is the importance of the keeping the Gestosis score for the patient. So there are other and newer biomarkers, of course, in prediction, and I'm not going to discuss all because it will take a long time, but some very important ones which are coming to the fore now are, of course, split and PLGF. And this was the first study which told us that ratio of split with PLGF of 38 or lower can be used to predict the short-term absence of preeclampsia in women with whom the syndrome is suspected clinically. And this is important because many times we are wondering the BP is slightly high and the symptoms and signs are suspicious. Then what do? If you have the availability, then one can do the split PLGF ratio. We know that it is anti-angiogenic and angiogenic ratio. And if it is less than 38, then we can say that this is safe. If it is more than 110, then definitely the patient is going to require an early treatment. So this is the SPREE study, of course, is a very famous study by the Nicolaitis group. And this used multiple biomarkers for prediction of preeclampsia in the first trimester itself. And they came out with impressive figures of 80% prediction of early onset preeclampsia. But we still have to remember that prediction for late onset preeclampsia remain still low with all these investigations. So if we can look at their figures, we find that they use maternal factors or maternal characteristics and went on adding either MAP or PAP or PLGF. And what we find here is, as we can see, when maternal risk factors with MAP plus uterine artery Doppler plus PAP and PLGF are assessed together, the predictivity of early onset preeclampsia is 81%. But late onset preeclampsia is still 43.5%. And that's why, as we said, the gestational score, because the clinical assessment still remains important, especially in low research settings. So what is present consensus about the prediction? The universal screening is recommended, but there is no single effective screening test. None of the tests proposed till date to predict at-risk population of preeclampsia qualify to be recommended for the general population screening. Thus, assessment of clinical risk factors, like in Gestosis score, helps us to be more vigilant. Careful history taken early in the first trimester can warrant attention for effective prediction and prevention towards mothers at risk very early. What does FIGO and ISSSP say? That no first or second trimester test or set of tests can reliably predict all cases of preeclampsia. However, a combination of maternal risk factors, blood pressure, PLGF, and uterine artery Doppler can select women who may benefit from aspirin to prevent preterm but not term preeclampsia. FIGO and ISSSP support first trimester screening for risk of preeclampsia when this can be integrated into local health system. That is very important, because in Western system, it's available, they can afford, but at our periphery, the uterine artery Doppler in the first trimester with the needed expertise or PLGF or not be available or affordable. And so the cost effectiveness of this approach remains to be established as yet. There are other interesting biomarkers on the horizon. One such is the Congo red. This Congo red test is a urine test, and it assesses the global protein misfolding load in pregnancy based on urine congophilia. And it carries diagnostics and prognostic potential for preeclampsia. This is urine test which identifies these proteins. This is under evaluation. And in some countries like in Bangladesh, they have tried it and with good effects, but universally it is still to be accepted. We ourselves are developing a test with serum endoglin, and we want to have this test as a point of care device, just like our pregnancy test situation. So we have created something like this marker, which you can use, put a serum, drop of serum, in the indicator plate, and you will get the assay results. Now this we validated in about 300 patients so far, and we applied for the patent, and hopefully, in few months' time, we will be able to validate it further and make it available at a very cost-effective place. That's what we are hoping. So from there, we come on to the clinical and laboratory evaluation of the hypertensive diseases in pregnancy. This is very important if you have to manage a particular patient. And nothing is more important while talking of hypertensive diseases than the proper blood pressure assessment, and because that's the crux of the matter. And that's why, all these points, I'm not going to read through that, but all these points that I have mentioned here that are important, that take the blood pressure as in the OPD in the sitting position with the blood pressure apparatus at the level of the heart of the patient, and make sure patient is relaxed, and all these points are taken care of, and then go for Korotkoff 5 sound, as we know, when you're taking the diastolic blood pressure. When it comes to symptoms and signs of preeclampsia, the problem is these symptoms are extremely non-specific and vague. Sometimes the patient are not even symptomatic. There may be a swelling, headache, vomiting, oliguria if you are careful to. And of course, later on in severe situations, visual symptoms like blurring. And one thing one has to remember that any patient who comes to us for vomiting and epigastric pain, during the second trimester, don't think that it is just extended hyperemesis gravidae. We have to really think of even the something like developing HELP syndrome, and that's why this condition we should heed to practically when the patient is in second trimester. So, what are the physical findings? Hypertension, proteinuria, non-dependent edema, reflexes, ankle clonus. All these are well described in the textbook, so I will not go through them again. Investigations, of course, are important for any patient, and we have to decide which investigations we can easily carry out and in our own situation. So, urine analysis by proteinuria, it can be by dipsticks, or also 24 hours urine collection, full blood count, especially platelets and hematocrit, renal function, uric acid, serum creatinine, liver function test, and coagulation profile. So, measurement of proteinuria with dipstick, though it's not 100% proof. It can be false positive or sometimes even false negative, but significant proteinuria should be defined as more than 0.3 grams per day in a complete 24 hours urine collection, or when the urinary dipstick proteinuria is more than or equal to 1+. Test can be done at a shortened time interval, and the abnormal protein creatine ratio more than 30 gram per millimole or 40 gram is the cutoff in multiple pregnancy. But do remember that urinary protein to creatinine ratios predict the 24-hour urine total protein level and may provide a faster, simplified method of estimating proteinuria, providing that the protein values are less than 1 gram in 24 hours. However, ratio of less than 0.2 effectively excludes the presence of significant proteinuria. And a cutoff ratio of greater than 0.19 is a good predictor of proteinuria. And when it comes to proteinuria, we have to remember two things: that as we saw in the new definition, proteinuria is now not a must to diagnose preeclampsia. That's one thing. And secondly, the increase, people keep on saying, well, it was yesterday it was 1+, now it was 2+, now it is becoming 3+. The increasing proteinuria does not tell you anything about prognosis of the patient. Once it's diagnosis proteinuria, it's proteinuria. So there's no point in again estimate how much is the proteinuria. Then a complete blood count, anemia status, and thrombocytopenia. But again, here we have to remember that there is hemoconcentration, and that's why false correction of anemia may be seen in these situations. Then total leukocyte count will identify current infections which may aggravate the condition. Renal function tests are, of course, important to give us the status of the kidney and serum electrolytes health in fluid management. Liver function tests, of course, elevated liver enzymes are the markers for severity of underlying HDP. And especially in HELP syndrome, we have to remember that only the enzymes go up. Enzymes are more than double in that situation, while bilirubin may not be on the higher side. And this is a hallmark of the liver function test in HELP syndrome. Coagulation profile is done. If you don't have the facility, then wait. You can do only the platelet count. See if the thrombocytopenia is there. If thrombocytopenia that is less than 1 lakh count is there, then of course you have to worry about the coagulation situation. Then the differential diagnosis for severe preeclampsia, of course, would be renal disease, acute fatty liver, cholestasis of pregnancy, hemolytic uremic syndrome, thrombocytic thrombopenic purpura, pheochromocytoma. Most of these are fairly rare situations. Now we come to the management of preeclampsia. And of course, the management needs to start with the antihypertensives. Now, when it is a question of severe hypertension, all guidelines agree that severe hypertension more than 160, 110 require urgent treatment in a monitored setting. Acceptable agents for this include oral nifedipine or intravenous labetalol or hydralazine wherever it is available. Oral labetalol may be used if these treatments are unavailable, but the dosage have to be really properly adjusted. Now, when it comes to mild hypertension, there is a lot of controversy. You will find the NICE guidelines or even SCOG guidelines saying there is no need to really have a tight control. But in recent consensus, the World Organization, Gestosis and ISSHP have agreed that the blood pressure consistently at or above 140/90 millimeters should be treated, aiming for a target diastolic BP of 85 millimeters to reduce the likelihood of developing severe maternal hypertension and other complications such as low platelets and elevated liver enzymes with symptoms. And this is based on the CHIPS trial. And what was this CHIPS trial, which was conducted by the ISSHP group and Laura Maggie and her team? And they looked at the effects of less tight versus tight control of hypertension on pregnancy complications. Women were randomly assigned to less tight control, targeting the diastolic BP at 100, or tight control, targeting the diastolic BP at 85%. They found that there was no significant between group difference in risk of pregnancy loss or high-level neonatal care or overall maternal complications. But less tight control was associated with a significantly higher frequency of severe maternal hypertension. And that's why the tight control does benefit the patients, and that is what we advise nowadays. What are the drugs and dosages that we can use? Methyl dopa, labetalol, and nifedipine are very standard. There are many other antihypertensives, but I think if we just stick to the standard available ones, then that's good enough for practical management. And which drug one would choose? The first line, either if you have the methyl dopa available or labetalol, or second line can be nifedipine. But this will depend, the good guideline to follow is that if the pulse rate is more than 100, then you can use labetalol as the first line. If it is less than 100, then go for, nifedipine, because their actions, vary accordingly. So again, a little detailed description of management of severe preeclampsia. As we said, we have already defined the severe preeclampsia in this particular manner. So let's not again in whole definition, but we have to again emphasize that delivery is always an appropriate therapy for mother, but may not be so for the fetus when we think of management of severe preeclampsia. If there is a rationale for management other than delivery, it would of course be to palliate the maternal condition to allow fetal maturation and cervical apnea. So if we get a couple of days for maybe achieving maturity by giving steroids or so on, that does our cervical ripening to deliver the patient normally, that would be an indication to wait if everything else is safe. So the principles of management are safety of the mother and the fetus, hospitalization should be prompt, and IV Maxil should be used to prevent convulsions, and antihypertensives to prevent complications. So when you are talking of urgent control with drugs, then it is good to use either intravenous or intramuscular labetalol. There are various regimes which I'll show you in the next slide. And of course, nifedipine also can be used quite effectively in this situation. And but one has to remember the maximum doses that we can use in here. One thing, please remember that don't ever give nifedipine sublingually. We are many times in a hurry, and we give nifedipine sublingually. That can really reduce the BP to a great extent suddenly, and patient may land up in shock and trouble. When it comes to labetalol, there are various regimes. As we know, it's alpha-1 and non-selective beta blocker. There's a Parkland regime, where one can use 10 milligram of IV to labetalol, and if the BP reduction is not achieved in 10 minutes, then 20 milligram is given. Next 10 minutes incremental dose is 40 milligram, followed by another 40 milligram if needed. So there is SEBI regime and NHBP SEOG regime, but I think Parkland regimes suits us fine in our own circumstances. Then when we are talking of antihypertensive therapy, we have to remember that BP should be lowered to definitely less than 160 and 110 millimeter. The initial antihypertensive therapy should be with nifedipine short-acting capsules or parenteral labetalol. Antihypertensive therapy, the second line after this can be NTG infusion, or really one can use in an ICU situation sodium nitroprusside. The points to remember are, we used to be worried about using nifedipine with magnesium sulfate together, but after a lot of experience, one has found that this can be safely used. But one has to remember that magnesium sulfate is not recommended solely as an antihypertensive agent. It can prevent eclampsia, but it cannot solely reduce the hypertension. Continuous FSS monitoring is advised till the BP and blood pressure is stabilized. And what are the actual actions that we have to look for? That BP should be confirmed after 15 minutes while diagnosing. If it's severe hypertension, antihypertensive medication should be immediately resorted to. Severe systolic hypertension is independent risk for stroke that we cannot forget, and short-acting antihypertensives successfully lower maternal BP in more than 80% of the women. So for our country, nifedipine is a very, very safe drug. Failure to treat the severe hypertension or preeclampsia has been identified as a single most serious failing in the clinical care of women who died. And this is the finding from the UK confidential registry. So acting fast in hypertensive situation is very important. And there is, of course, what is called as an hypertensive emergency. It is associated with end organ complications such as eclampsia, and mandate immediate lowering of mean arterial pressure by no more than 25% at a time, but to 160 to 100 millimeters. Hypertensive urgency is without end organ complications and may be treated with oral agents with peak effects in 1 to 2 hours, such as labetalol. Prevention of seizures, one cannot emphasize adequately. Prevention of seizures is very important, and magnesium sulfate is recommended for prophylaxis. The full dose of magnesium sulfate should be used. What one would advise is, people are scared that once you have used magnesium sulfate, maybe when the patient is having severe preeclampsia at 30 or 32 weeks, then you will have to immediately go ahead and deliver the patient. That is not so. The patient stabilizes, then you can again, of course, after hospitalization and watching patient carefully, go in for expectant line of treatment further. And that's why one would say that use of magnesium sulfate, our threshold should be now much lower than before for prevention of eclampsia. And of course, we all know that the neonatologist also advise now magnesium sulfate for protection of sort of neuronal system of the baby. And so in very premature babies also, maybe 26, 28 weeks, magnesium sulfate is very much indicated to protect their CNS system. Management of severe preeclampsia is based on, of course, gestation age. Delivery is the cure for preeclampsia, but expectant management, as I said, is attempted with an effort to decrease the effects of prematurity or to optimally promote fetal maturation. It is agreed that the delivery should be planned if the mother reaches 34 weeks or develops the condition after 34 weeks, as severe preeclampsia is associated with severe maternal and fetal morbidity. So then what are the indications for expectant management? Expectant management can be considered in pregnancies at less than 34 weeks of gestation if there is no evidence, that is the important part, no evidence of organ involvement, thrombocytopenia, HELLP syndrome, symptoms of cerebral irritation, labor, abruption, and immediate danger to the fetus if pregnancy is prolonged. So if all this is not there, one can think of, expectant management. So what are the principles of expectant management? It is desirable to be undertaken in a good, well-equipped facility. May not always cheap, but at least be equipped facility. Anesthetic, neonatologic, and obstetric and operating room staff should be available round the clock. There should be defined surveillance guidelines for expectant management and delivery in these mothers. Okay, but what if severe preeclampsia is seen before 25 weeks? We can consider that, now, unless in rare circumstances, 24 weeks and below, the pregnancy is rarely salvageable and the fetal prognosis is very poor. And that's why in these situations, early delivery for maternal causes is very important. So early onset severe preeclampsia should have an evaluation for secondary causes of hypertension, or it may be superimposed preeclampsia in a mother with chronic hypertension too. Severe preeclampsia between 25 and 34 weeks of gestation. Here, expectant management, as we have said before, has a role corticosteroids to improve the lung maturity of the baby, and betamethasone 12 milligram 12 hourly in 2 doses, or dexamethasone 6 milligram 6 hourly in 4 doses is intramuscularly is the standard treatment. Maternal monitoring should be carefully done in expectant management, and the BP monitoring every 4 hours. Then the lab monitoring should be there. The test to evaluate effects of disease and progression like platelet count, LDH, transaminases, and serum creatinine, all should be done. And of course, fetal monitoring, the least is subject to fetal count, but daily assessment with NST, amniotic fluid index, and estimated fetal weight by ultrasound, at least, all these things, at least ultrasound should be done twice a week if we are to manage these kind of patients. And indications for delivery, of course, will be maternal indications and fetal indications. If the disease progresses, if we find that the complications are occurring which are enlisted here, then of course one has to go for indication as maternal delivery indication. Then of course fetal delivery indications are there, and severe growth restriction, decelerations, oligohydramnios less than 5, umbilical artery Doppler waveform showing absent or reverse diastolic flow, fetal death, and CPR affection. So these are the simple WHO guidelines. I think, if you put that up, for your staff to follow, this becomes very easy for them to understand. I'm not going to go through that in details, but gestational hypertension, mild preeclampsia, severe preeclampsia, and eclampsia, just one chart will help you, guide your management. Then, of course, talk of the timing of the delivery. Women with preeclampsia should always deliver at 37 weeks of gestation. When we say that, people will say, but no, we have, supported, managed the patient very well. So can we not, go for, at least 1 week more to achieve maybe survive happening and deliver? In our situation, when we want to avoid cesarean section, certainly, these things are not an exception, but as a guideline, we have to tell the people that deliver at 37 weeks, because the complications later on are sometimes unpredictable and sudden. And that's why these kind of studies which are done, this is a HYPITAT trial which came in 2009. What this HYPITAT trial told us, they allocated 756 patients, women with gestational hypertension and preeclampsia without severe features after 6 weeks of gestation were allocated to expectant management or induction of labor. The later option, that is the induction of labor, was associated with a significant reduction in adverse maternal outcome, including new onset severe preeclampsia, HELP syndrome, eclampsia, pulmonary edema, or placental abruption. There were no differences in the rates of neonatal complications or cesarean delivery. So induction of labor was recommended. So if you see, these were the patients without severe features of preeclampsia. And even then, this made a difference. Then HYPERDA 2 trial which came in 2015, they randomized the investigated immediate delivery versus expectant management and between 34 and 37 weeks of gestation in women with, again, non-severe hypertensive diseases. What they showed was immediate delivery through either induction or, if indicated, elective cesarean section might reduce the small risk of adverse maternal outcomes compared with expectant monitoring. However, immediate delivery may increase the risk of neonatal RDS. So here, again, we can take a call as per our preparation for neonatal care and decide what we are going to go for expectant management or not. But the Phoenix trial that came in 2019, this trial also brought out strong evidence to suggest that planned delivery reduces maternal morbidity and severe hypertension compared with expectant management with more NICU admissions for prematurity, but no greater neonatal morbidity. This trade-off should be discussed with women with late preterm preeclampsia to allow shared decision-making on timing of the delivery. Right. Now we come to the intrapartum management, and I'm not going to again go into the details of it, but in addition to appropriate management of labor, two main goals should be there: that prevention of seizures so use magnesium sulfate, liberally, and control of hypertension with nifedipine and labetalol. The mode of delivery will depend on urgency to deliver, cervical Bishop score, gestational age, severity of fetal growth restriction, and Doppler study findings in the umbilical artery. It is preferable to conduct delivery, of course, in well-equipped facility. The induction can be done with prostaglandins. They are not contraindicated, especially the prostaglandin, gels or, mesoprost, if you're fond of that. Mechanical dilatation of cervix can be used, or augmentation of labor with oxytocin is also allowed. Severe cesarean delivery with severe FGR or reverse end diastolic flow on color Doppler or any obstetric indication for delivery. What is important is the fluid management. Appropriate fluid management is a must. Otherwise, one can land up with pulmonary edema, quite frequently. Fluid restriction to 80 ml per hour or 1 ml per kg per hour to reduce the risk of pulmonary edema is very important, and this has to be with anesthetics. Otherwise, initial loading that they do lands the patient in pulmonary edema soon, after the baby is out. Again, an important aspect is postpartum hemorrhage. This is definitely more because of magnesium sulfate. If we use it, can keep the uterus relaxed for some time. Active management of third stage and prophylactic administration of oxytocin and prostaglandins, if required, can be used. But of course, we all know that methyl ergometrin is absolutely contraindicated. And what we again have to note that average blood loss of labor may not be well tolerated by these patients because they already have hemoconcentration, and the blood pressure readings could be misleading also, because if you might find that 110/70 patients still can be in shock because the original BP was fairly high. So be careful in these reading, and so preventing PPH is important. Then, of course, eclampsia management. Again, rather than going into the details, I would mention that you need to have a checklist always, ready, and this will include the well-equipped room, oxygen, maternal and neonatal resuscitation facilities, eclampsia kit, protocols, and documentation. All should be in place as shown in this figure. And we don't have time to go into the absolute details of it, but always this eclampsia preparation is very important. Monitoring for the patient is vitally important, but don't worry about magnesium sulfate. People don't use magnesium sulfate thinking that, oh, it is toxic, it may cause respiratory depression. It's not at all easy to cause, respiratory depression, and don't, be afraid to use magnesium sulfate for these reasons, because as you can see here, the magnesium sulfate level will have to be really high, and you can monitor by respiratory rate or patellar reflex or urine output, and don't have to worry about even doing all the studies, especially if you don't have the proper facilities to go for the actual evaluation of the levels of magnesium. The most popular regimen in our countries, of course, the Preacher's regimen with intramuscular 5 milligram and in both buttocks and loading dose of 4 grams. Again, this chart should be always put up in the labor room so that it can be easily followed anywhere, so that we don't have to, worry about what people, because last minute when the patient is convulsing, one is always worried about what's, and one messes up with the dosages. Now we come to the post-delivery management, which is again extremely important. It involves close vigilance for eclampsia, PPH, health, pulmonary edema, cardiovascular and cerebrovascular events, and thromboembolic complications. Our national eclampsia registry showed that 13% of the cases, the eclampsia occurred first time after delivery. And postpartum use of NSAIDs should be, that's why avoided. They can cause problems. Antihypertensive therapy and magnesium sulfate should be considered for seizure prophylaxis. So even if you are escaped and not used magnesium sulfate before, if the blood pressure increases, immediately you can use magnesium sulfate to, especially the patient gets, headache and, premonitory symptoms, use it liberally. Use of pulse oximeter is important, especially on 3rd and 4th day, the blood pressure rises, even if you managed it well before. So continue with your antihypertensives, and before discharge, at least not only measure the blood pressure on 3rd or 4th day, but also look at the SpO2. And if SpO2 is less, 95 or less, this patient is in trouble. She may land up with what is called as atypical, severe preeclampsia later on, or even cardiomyopathy, and that's why this patient may be kept under observation for further time. So what are the future trends now? We have discussed about, I know I have not covered absolutely everything, but I've tried to cover as much as possible about what we can expect now as future trends in this management. So now we are recognizing that, there is a lot of clinical variability in preeclampsia. Clinical variability as per the gestational age of the occurrence, severity of the symptoms, presence or absence of very high blood pressure, variable rate of progression, recurrent versus non-recurrent preeclampsia, with or without, fetal growth restriction, then preeclampsia with or without proteinuria, with or without organ involvement like liver and kidney, and with or without obvious predisposing factors. So when we look at preeclampsia, the question is it a single syndrome, or are we looking at various subtypes and not just variable presentations here? So just like, there was people later on found that type 1 diabetes was different than type 2 diabetes altogether. Of course, we now know that early onset preeclampsia is much different than late onset preeclampsia. But there are still many subtypes, and we have to hit to those subtypes. And what are these potential subtypes? They can depend on clinical presentation, like early or late, severe or mild, and with or without FGR. Epidemiology-wise, recurrent or early onset. Pregnancy phenotype may be different depending on BMI and all that. Demographies, race and socioeconomic status, ethnicity, and pathophysiology paths to hypertension. So how do we recognize these subtypes? Because that's very important that in future we do that and individualize the treatment more and more. So first we need to have the awareness and not to assume that all preeclampsia is the same, not to force all data to fit into one model, and to pay attention to the outliers too. we have to be open-minded and look at the data without preconceived idea. And this is where I would like you to introduce to this landmark study which is done. And this has now, looked at the gene expression profiling, like of various cases pertaining to preeclampsia. And Catherine Levy et al. Created a large clinically relevant human placental microarray data set and applying gene clustering. This may appear complicated, but this is the future, and we have to look at this carefully. And they recognize that there are 3 clinically significant etiologies when you look at the gene mutations in these various placentas. So first will be the maternal type with healthy placentas and term deliveries, which are normal. Then secondly, canonical or very typical, exhibiting expected clinical and histopathological features of preeclampsia, either early or late. And immunological with severe fetal growth restriction, where fetal growth restriction is more evident and that shows the evidence of maternal anti-fetal reduction. So, solely based on the similarities in gene expression, the proposed model of placental outcome and preeclampsia etiologies, and 4 different clusters that we could identify with this gene expression profiling help us denoting different subtypes. So this is going to be the future. Looking at the genetics of all these conditions. Now, when it comes to genetics, the epigenetics cannot be far behind, because epigenetics is something that helps us modifying the gene expression, and that's why we may have some treatments or preventions coming in future if you look at the epigenetics. And we know that emerging evidence also suggests that healthy placental function requires locus-specific methylation changes at specific time points in development. And maternal exposure to severe stressors such as environmental pollutants, nutritional factors, psychosocial stress, or maternal depression during pregnancy can increase the fetus risk for suboptimal growth in wide range of organ systems and for developing a variety of disorders in the adulthood. Something that we also know as Barker's hypothesis. And now we know that there is a clear relationship to what happens before or during pregnancy. And that's why this is something that we can act on and see if we can modify. So these epigenetic regulations play a role in the phenotype pathophysiology of preeclampsia. And interestingly, placental gene expression changes have been shown to precede preeclampsia, and candidate gene susceptibility loci where they occur are now being identified. And this has wide-ranging implications in the discovery of predictive markers for preeclampsia, which may improve the ability to provide early treatment and monitor women with high risk of preeclampsia. So what is in future as a treatment? Do we have a treatment for preeclampsia? Well, so far we are only, treating the symptoms, only hypertension and, seizures with magnesium sulfate and so on. And trying to prevent at least early onset preeclampsia by low dose aspirin and, calcium supplementation. So if we study the subtypes, we will come to know that there are risk factors which are driving the subtypes. So age, BMI, nutrition, paternal profile, which we have neglected so far, pregnancy profile with ICSI, OD, stressors during and before pregnancy, and genetic and epigenetic factors. So if we look at this, this will give us some guidance as to what we can expect, how we can predict, and how we can try and modify the situation also. And that's why there are now new treatments being tried. And these are, there are a lot of series with metformin used for prevention of preeclampsia, pravastatin used for, prevention, melatonin has been used for prevention, esomeprazole has been used for prevention. And the latest on the list, and this is probably going to be a game changer, that Karumanchi's team has now come up with mRNA intervention with split. So split levels, if we can actually reduce with mRNA intervention, just like we use the mRNA vaccines now, then this may make a difference, a total difference in management. This is, of course, still experimental, being used in but that can be the future treatment. And we will have a real treatment for preeclampsia in future. So before I close, two vital concepts that I would like to again emphasize on. One is the Gestosis clinic, especially in large hospitals and especially in in the medical colleges. There is, and even if you have a good obstetric practice, BC obstetric practice, you can think of Gestosis clinic for your, because this can create awareness and counseling, early prediction, maternal alerts, and especially opportunity to discuss long-term preventive strategies with women who develop preeclampsia, as they are at increased long-term risk of chronic hypertension, IIT, cerebrovascular disease, kidney disease, diabetes mellitus, thromboembolism, hypothyroidism, and impaired memory later on in their life. And that's why the eclampsia or preeclampsia treatment doesn't get over when we have delivered the patient and the patient is, so-called safe. We have to keep on following this patient for years together. And that's why one should have not only an obstetrician, but counselor, nutritionist, then lab backup and good sonology backup and other specialists as and when required. And together, if we counsel this patient and tell them what they can expect in future, also will really make a difference. So there is a huge role now, in our hospital, diabetes and pregnancy clinic separately, where diabetologist and nutritionist and all are available with counselors, and also Gestosis clinic. And that has made a lot of difference in management, because, the important part is to make patients aware when she comes with some edema and we tell her that her BP is 150, 100 and she is at risk. She has come to you walking and the relatives say, what are you talking about? The patient is absolutely fine and we are talking about patient being serious and having complications. So creating that awareness and counseling, we need help. We as obstetricians cannot give always time for doing this. So Gestosis clinic is important. So in conclusion, I would like to urge you that we have a great responsibility to reduce unacceptably high morbidity and mortality due to HDPs in our patients. And hence the Gestosis score and the Gestosis clinic should now become an integral part of our obstetric practice. And I would also like to, urge you, it's your wonderful and new society. So we have, as you know, the Gestosis Society of India, the chapter of International Society. And I would like you all to be the members of that. And maybe we can create a database at your own place for your patients, and we'll help you doing that if you all become, the members of this Gestosis India chapter of Gestosis Society also. So, thank you very much for, kind listening. And if there are any questions, I'll be most happy to entertain the, questions, because of course, I've talked for a long time, but I still couldn't cover all the issues. But if there are still questions, they're welcome.
So that was a beautiful presentation, sir. So much of new information was shared, and thank you for the update, sir. I have a question.
Sure.
Group of women should be offered MRIs, especially the postpartum women should be with eclampsia, should be offered or a select group should be offered.
Right. If you are in a tertiary center, if the facilities are available, and then we have heard of what is called as PRESS syndrome, right? And that's why for that, the MRI would be a diagnostic feature. But even if you have this PRESS syndrome, or even sometimes blindness in these patients, the reassuring factor is if you manage the patient well, there is no long-term damage to these patients. Don't worry if you do not have the MRI facility. If you have, and if you are research oriented, definitely you can offer it.
So what about mannitol, sir? Is it offered to women with sir?
See, previously we definitely used to use mannitol when we were resident doctors. Nowadays the mannitol has got a backseat, because the good antihypertensives are available, and magnesium sulfate given in a good dose makes a lot of difference. And we know if we take care of preventing stroke and eclamptic seizures, then patient will recover in time to come. We have gone through all that era when, all Krishna Menon's regime was there, mannitol was there in our younger days. But now the treatment has become more specific. And I think if we stick to that, I think we'll, guide our doctors properly.
Thank you, sir.
Thank you for that very extensive presentation. If anyone else has any queries, you can please ask sir, or you can even type it in the chat box. Sir is more than willing to answer all our doubts.
Sure. See, when it comes to preeclampsia, each of the topics that I took over, like prevention, prediction, then I didn't touch the, pathophysiology, because sometimes it becomes non-clinical. All those can be separate lectures for 1 hour together, So yeah, there's no end to it. So I was trying to keep it as practical as possible.
I think you did succeed in the same. So it was very practical, and for us, the clinical scenario, I think it answered most of our questions. So I would like to thank you for that extensive presentation.
Sure.
It was very helpful for us, and hopefully we have you, address our gathering on many more such occasions. So thank you
absolutely. That will be my pleasure. And I share with you the link to the Gestosis membership also. And I think all of you can
I will
join that.
Hopefully.
Certainly. Dr. Suchitra Pandit, she is the president of the India chapter. And I'm looking after, of course, the international organization. But we have now a good number of, more than 1,000 members of this Gestosis Society, specifically working in preeclampsia, eclampsia field.
Sir, I think we have a question which has been, someone has typed in the chat. Dr. Radhika,
Sure.
I guess. Yeah. Sir, is there any role of anticonvulsants is Madam's question.
Okay. So as far as preeclampsia and eclampsia, means severe preeclampsia and eclampsia is concerned, the magnesium sulfate is now absolutely the standard treatment. Now, if you have a very rare case where you use magnesium sulfate, even in a continuous intravenous dose, like and still, if you keep on getting recurrent eclamptic seizure, which will be very, very, very rare, then maybe you can use anticonvulsant, or people have even used in previous time pentothal and all. But believe me, this now with a good management and proper dosage of magnesium sulfate, this is very, very rarely needed, and definitely not as a first choice. So Dilantin and all that we used to use, or compose, definitely as a first choice. Choice always should be magnesium sulfate.
I hope that answered your doubt, ma'am. Thank you once again, sir. Actually, we learned about the Gestosis committee on this platform. Till now, we were not actually aware of this committee. So I'm sure we'll all enroll in the same in the future. Thank you once again. I would also like to thank Shield Pharma for organizing this event, and primarily for introducing such an eminent speaker to us. So thank you all, and I thank all the delegates who logged in today. I think we reached around 28 to 30, I guess. So thank you all once again, and hope to meet you all in the near future. Ours is a very small society, sir. So I think
no problem. I think it's always better to discuss with smaller groups, and because they are more committed and they're more interested. So I definitely enjoy it. The numbers don't matter. It's the interest of people that matters.
Very true, sir. And
I can see Mr. Yes, I can see Mr. Balaji of Shield, and I think he may want to say.
I sincerely thank Dr. Sanjay Gupta sir for accepting the request of this society, and Madam for giving us this opportunity. Thanks from Shield. That's all from my side, sir.
Okay, thank you all. Thank you.
Thank you, sir.
Thank you so much. Thank you, sir. Thank you, Madam.
Yeah, thank you. It was a pleasure.
Thank you.